Hello, and welcome to Room Now. We're going to be discussing as a group the interleukin-17 inhibitor studies that were presented at ACR 2024 Convergence. My name is Dr. Philip Mease. I'm a rheumatologist based in Seattle, director of the Rheumatology Research Program at Providence Swedish Medical Center, and clinical professor at the University of Washington. I'm joined today by Brian Jaros, who is joining us from Northwestern University, where he is starting off as a bright and energetic faculty person in the rheumatology division there. And so an up and coming rising star to take the place of us oldsters here. And then also by Peter Nash, who I think everyone knows. Peter comes to us from down under. He's at the Griffith University School of Medicine in Brisbane. I've had a chance to visit with Peter there, including this time on the golf course when we were joined by kangaroos. And we have a delightful photograph of me sort of standing near a
hiding behind your wife.
Near a puzzled-looking kangaroo because I was getting in the way of his putting. Okay, so to start us off, let's on a more serious note, let's get to the IL-17 abstracts. And I'll start with Brian, if you want to jump in with choose one of the abstracts, and then I will follow you, and then Peter after me.
Excellent. Thanks for having me. So I'll be first presenting, this was abstract 1757, the treatment in MRI inflammatory and structural lesions using a subset of patients from the B-Mobile 1 and 2 trials. So as probably a lot of this audience knows, especially after this ACR Convergence, Bimekizumab is the new monoclonal antibody, and it's unique in that it binds both IL-17A as well as IL-17F. And the B-Mobile 1 and 2 studies looked at outcomes of patients with radiographic and non-radiographic ankylosing spondylitis, and showed clinical efficacy with bimekizumab. And so this sub-study was looking specifically at imaging outcomes of bimekizumab in a group of patients from B-Mobile 1 and 2 who had MRI data at 3 time points, at baseline, at a 16-week time point, and a 52-week time point. And the way the trials were set up is that from 0 to 16 weeks, it was bimekizumab versus placebo, and then at week 16, all patients would switch over to the bimekizumab arm. And they used SPARC, sacroiliac joint inflammation scores, and structural scores to try to objectively characterize, using 2 independent readers, over these time points, how inflammation changed. And so they had a good number of people, around 50% of the patients from the trials had enough MRI data to be enrolled. And the results were pretty profound. At week 16, they saw the bimekizumab group for non-radiographic ANG-SPA, almost 2/3 of patients had what they called MRI remission, which they characterized by a SPARC SIJ score of less than 2. And 58% of patients in the radiographic group, so both groups experienced quite a good response. And that was compared to about 1/4 or less of patients in the placebo group. And then when they looked at week 52, the patients who had been on bimekizumab from the start saw even greater incremental gains in remission, going all the way up to almost 75 to 80% of patients achieving MRI remission. And the patients who crossed over from placebo saw a great increase in remission as well, and about somewhere between 1/2 to 2/3 of patients in the crossover groups achieved MRI remission. And then beyond that, as I mentioned, they looked at structural scores, not just inflammation, but things like erosions or evidence of structural damage. And they saw that reductions in erosions were significantly improved in the bimekizumab group compared to the placebo group, and also observed again in those who crossed over. So I thought this was a nice additive study to the clinical data that we saw in B-Mobile 1 and 2 that showed us how this might almost contribute in a, if you want to call it, disease modifying aspect from an imaging standpoint. And also that by week 16, which is a very, relatively short period, there were already significant gains in MRI and imaging improvement scores.
That's terrific. So as you know, this drug was just approved about a little over a month ago in the US for use in psoriatic arthritis, as well as both the full spectrum of axial spondyloarthritis. So this is a welcome addition to our armamentarium for agents that can be effective in axial spondyloarthritis. We don't have that many. We've got the TNF class, we've got the JAK inhibitor class, now the full IL-17 class. So this is very important data. And we're going to hear more about bimekizumab in this session as well. But what I'll take on with right now is a new agent that's we're just beginning to see data on, and that is called Sonelokimab. This is a fascinating drug, which is also an IL-17A and IL-17F inhibitor, so a dual mechanism similar to bimekizumab in that regard. But it's a nanobody. It's a small molecular entity, 40 kilodaltons, as opposed to the 150 kilodaltons of a standard immunoglobulin like a monoclonal antibody. The reason that there's a lot of excitement about nanobody biology is that there is data in humans in oncology studies and also mouse data that suggests that a nanobody construct may have better capability of penetrating into difficult to penetrate tissues. And the perfect example of that is our cancers, which have are maybe poorly vascularized and just in general are hard to penetrate therapeutically. So we don't know yet whether that's going to really be the case and be an advantage in treating our conditions, our rheumatologic conditions, but we have now data from phase 2 out to 24 weeks with this medication in psoriatic arthritis patients. So this phase 2 trial involved three different doses of sonelokimab, or dosing regimens of sonelokimab compared to placebo. And there was also an adalimumab reference arm. There are approximately 40 patients in each of the different arms of the study. And we've seen previously the week 12 data. This was presented at the EULAR meeting. And now we're seeing 24-week data. And for example, the ACR50 endpoint, which at week 12 was 37% of patients achieving this in one of the sonelokimab dose arms. This went up to 59% at week 24. The other two dose arms had a similar increase, including starting at 46% at week 12, then going up to 61% at week 24. So really, really high threshold of response. And the other thing that was noted was that the placebo patients who after week 12 went on to sonelokimab were able to achieve 54%, achieving ACR 50. Other high threshold endpoints included the minimal disease activity achievement, MDA, and psoriatic arthritis. There are 7 items, and if you get at least 5 of them, then you're in a state of MDA. That's, for example, achieving a tender or swollen joint count of less than or equal to 1, an enthesitis score of less than or equal to 1, a PASI score of less than or equal to 1, as well as patient global, patient pain, and so forth. So at week 12, in the one of the sonelokimab arms, that was achieved in 44% of patients already. This was pretty high for achievement of this. We've often and historically seen levels like 30% of patients achieving an MDA response. And then at week 24, this went up to 62%. So quite a high achievement of minimal disease activity. They also assessed an interesting combination of achieving an ACR70 response and a PASI 100 response. So complete clearance of skin and a very high threshold joint response. And one of the sonelokimab arms went up to 48% on that particular dual outcome measure. So this is looking like a promising addition. It's also an IL-17A and F dual inhibitor. Safety signals were similar to what we've seen with other IL-17 inhibitors, including an occasional case of oral thrush, but in general, quite well tolerated. This is now proceeding into phase 3. Peter, do you have any comments about this particular approach?
Look, it looks very interesting, and it begs the question, if it smells like a 17 and tastes like a 17 and does like a 17, you've now got 5 of them, 6 of them, 7 of them, if you include the Russian one and whatever. How many do we need, Philip? And I think that the key question is, how do we pick amongst them all? And what advantage does one have over the other? And do they have less adverse effects or more adverse effects with? And we're desperately looking for evidence that blocking F is superior to just blocking A. And that was the abstract that I was going to talk about, if you wouldn't mind, that where we have common clinical problem, doing very well on 17 for a long period of time, and then intercurrent infection or something, and they flare. And do you change class or do you switch within class? And the Canadians from 4 institutions looked at a multi-center retrospective review, only a small number of patients, 43, but they had had prior exposure to SECU, ICSI, and brodalumab, which we don't have because of the background of depression issues that was never approved in our country. And the reason for discontinuation was mainly in efficacy over time. So they switched to Bimekizumab, and within 4 weeks, or by week 16, they'd picked up PASI 100 in 63% of them, PASI 90 in 84%, and IGA 0 at 96%. So there's some evidence that switching within class and adding F inhibition might be an advantage in that group of patients. And they did look at the Bimekizumab Radiant study, which was open label, and the same issue. SEC switched to Bimi for whatever reason. They picked up good response, particularly skin response over time. So I'm just looking for ways to try and pick amongst the 5 different IL-17 inhibitors, and whether there's a big advantage blocking F or whether there's a big advantage going as a nanobody. And I think we'll never get head-to-heads, really. So we're going to have to decide based on this kind of data. Over to you.
So one of the things that we are going to see in the future, there's a study known as Be Bold that is just launching, which is comparing Bimekizumab with the interleukin-23 inhibitor risankizumab, also known as Skyrizi. Do you have
just
any?
Started that trial as well.
So you all are participating. Oh, cool. So any comments or thoughts about that as that goes forward?
I think it's very important because the safety of the 17s and 23s are remarkable. They're starting to be used in combinations. The skin efficacy is fantastic. The joints, one has a bit of axial, the other has a bit of IBD. There's always a tiny wrinkle. But how do we pick amongst all these fantastic new agents when we don't have head-to-heads? And I think that's a very important study from a strategic point of view to know which to pick. And the only other abstract I was going to mention came from Czechoslovakia, where they asked the question, if you'd failed the TNF, which everyone's being pushed into because of biosimilars in the rest of the world, not so much where you live, but in UK, in Europe, the biosimilar TNFs are being demanded by NICE and other regulators. And if you fail that first TNF, where should you go? Another TNF or a 17? And these guys looked at 127 patients and followed them and found that there was very little difference in retention between the two. And there was only minor differences in disease activity improvement between the two. But the 17s were much safer. They had half as many serious adverse events. They had half as many AEs in general. So like you and I have been saying for a long time, we're used to starting a TNF, but you can't show a difference in efficacy, whether it's Spirit head-to-head, whether it's Exceed, whether it's the Surpass in the spine. So the efficacy is the same, but the safety is very different. And so which should you use first, Philip? TNF or 17, either in PSA or AxSpA?
Well, oftentimes some of my patients will say, boy, I've heard this story from you about efficacy and safety. It sure sounds like we should start an IL-17 because of the safety. And I'll say, well, sorry, the formulary manager is going to push us in the direction of a TNF. They're going, what? Oh, well. All right, Brian, do you have a second abstract for us to
Yeah,
chew on?
piggybacking off that exact topic, this was looking at a similar question to the abstract Peter was just mentioning, except this was from the core Avitas registry of PSA and SPA, and this was again after these patients were started on a first TNF that was then discontinued due to clinical inefficacy. Does cycling to a different TNF or switching to, this was specifically IL-17A inhibitors, is there a difference in outcome between patients? And so the group looked at this registry again, both psoriatic arthritis and axial spondyloarthritis, and stratified them kind of into two cohorts, analyzed them separately, and used, our major kind of outcome metrics, the BASDI for the axial spondyloarthritis group and CDAPSA for the psoriatic arthritis group, and looked to see in those that were cycled to a TNF versus an IL-17 if there was a major difference between the two. And the short answer to that was no. They had similar primary outcomes between the groups. They were actually numerically higher in the did better in IL-17 groups, but not meeting statistical significance. But interestingly, a few of the secondary outcomes did meet significance favoring the IL-17 group, and that was patient-reported fatigue, actually, in the axial spondyloarthritis group was significantly improved with the IL-17 inhibitors. And the physician global assessment of arthritis and psoriasis in the psoriatic group was also significantly improved in the IL-17 switchers compared to those that stayed on the TNF. And so again, I think I'm not sure where, these outside of the limitations of insurance and those dictations where these fall in our armamentarium. I think it would be an interesting question. I don't know if this has been looked at. We in practice, I feel like we often try to differentiate primary versus secondary failure of a TNF to know if we should class switch. Did they ever have an adequate response that then petered out, or were they never responding from the beginning? And I wonder if we have the numbers or in these registries or groups to power looking at primary versus secondary failures and seeing if there's a more meaningful difference between those.
Sure. And of course, we need to take some of this with a grain of salt, since this is registry data as opposed to clinical trial data. But I love the way you said they. So it's mainly Alexis Ogden and I that are doing the Core Evitas registry. So I've been the scientific director of it since 2013. And what we try like crazy to get investigators to try to write down or mark off why they are changing therapies, but it's like pulling teeth to get them to really give us the full answer. And sometimes it's not clear. Sometimes it's efficacy, sometimes safety, sometimes it's administrative related to whether or not they can get the drug covered. But I think the Core Evitas registry really does a good job of collecting efficacy and safety data. So we collect all of the major outcomes that you do in a clinical trial, and we try to have well adjudicated, especially serious adverse events in the registry. So I think it's a pretty good one to get learning from. I think if we just had a greater N, we would have seen statistical significance. So just saying. So I'm gonna follow with one important abstract that was presented at the meeting, and this had to do with safety of Bimekizumab. Because this drug had been, it took a long time and various issues that led to a delay in approval by the FDA in getting it into the United States. We have out to 2 years of full safety data from the pooled phase 2B and 3 studies in both psoriatic arthritis and axial spondyloarthritis. So a huge data set, a total of 848 patients in the AXPA studies and a total of 1,409 in the PSA studies for a total patient year experience of 2,500 in the AXPA arm and 3,655 in PSA. It's unusual for us to have that much safety data right at the time that a drug is approved in PSA and AXPA. So what we have here are some of the factoids from that review. Number one, the incidence rate for serious infection was 1.4 in the AXPA group, 1.3 in patients with PSA. I think these are good numbers. For example, if you have AXPA or PSA patients without any treatment at all, the background rate of serious infection is likely to hover around 1 event per 100 patient years. So this isn't that much more than that. Although if this is not head to head, and it's hard to do a comparison, these rates are a little bit less than what we've seen with some of the other mechanisms that we use for treating PSA and AXPA. There was a signal for Candida. That's not a surprise, since IL-17 as a cytokine helps protect us from surface Candida. And so we saw some oral thrush. For the most part, this occurred once in the patients who experienced it. That was the great majority. A handful went on to have 2, 3, 4 episodes. Usually these were mild to moderate, easily treated with topical nystatin or sometimes diflucan. So this is an issue that we need to think about and maybe advise our patients about the possibility of it, but generally reasonably tolerated. And there were no systemic fungal infections. That's a key point because, as you know, with the TNF inhibitors, we sometimes see systemic fungus like histoplasmosis or coccidioidomycosis. Permanent discontinuation of bimekizumab was unusual for any adverse effect reasons. There were cases of inflammatory bowel disease. This is something that we know occurs as a class with IL-17 inhibition, and some of these were new onset. in the clinical trials, patients with active IBD were not allowed to participate, but you could have a history of IBD. And some of these cases were flares of previously known Crohn's disease or ulcerative colitis. So that too is a rare but important issue for us to be aware of. Otherwise, we didn't see a signal for adverse cardiovascular events, malignancy. So by and large, this was similar to the safety record that we've seen with other IL-17 agents, and I think it's a pretty tolerable one. And if, sometimes we get into using what I call dual therapy, like, for example, if I've got a patient with a really problematic case, I'll sometimes put two biologics together. And so I think this enters into the class of agents that has a really pretty good safety profile that I would not mind using as a dual therapy. Thoughts, you all, about safety factors?
I think they're very safe, the 17s in comparison. And for example, you're quoting 1.7 per 100 patient years. The TNFs, particularly in rheumatoid, where they're more likely to be on a little bit of steroid, a little bit of methotrexate, was 3 to 4 per 100 patient years. So that means if I treat 100 rheumatoids for a year, if I treat 25 rheumatoids for a year, I'll put one in hospital with a serious adverse event, usually infection. So we just take that risk on behalf of our patients, and it does drop off over time, but it's a different class. And I came across, you're asking about 17 versus 23. I found abstract 2585, Stefan Siebert's abstract, where he took 600 people from the PSA Bio observational study who started GUS or who started a 17, so the 23 or the 17, and they used PSAID from baseline to 6 months, and there was no difference in the minimal clinically significant difference. So, they're two very safe classes. It's nice to see BIMI, the AF. China's got an AF now. There's an AF nanobody. So we're going to have a plentiful supply of 17s, and I just don't know how we're going to pick amongst them unless there's an advantage. BIMI has strong numbers post TNF-IR, stronger than the others, but it tastes like a 17, smells like a 17, it works like a 17. So which one do we pick, Philip?
I'm going to leave that to you, Peter, and your unique situation in Brisbane. So, Brian, let me give you a couple of cases. Both of these are individuals where they have PSA. They've had a history of some diarrhea occasionally. No bloody diarrhea. So we ended up recently with such patients testing fecal calprotectin. And in one case, it was nearly 0. But in the other case, it was 162. So how would you have handled these two cases with respect to the class of drugs that we're considering today?
Yeah. So, I mean, I'm much more reassured in the patient with the lower undetectable calprotectin, common things being common, there's probably a host of other reasons to have diarrhea. And if there's without red flag symptoms and the inflammation is normal, I don't think that in particular would deter me from using an IL-17, for example, in that patient. The other patient would make me nervous. I feel like that's the flip side or the benefit, I suppose, of having a number of different agents that, again, maybe have slightly different risk profiles, but don't necessarily have head-to-head data suggesting that one is completely superior to the other in all patients. And so until that individual kind of underwent GI workup for, colonoscopy, et cetera, I think I would probably err on the side of caution and avoid a 17, knowing that there's other classes that, could probably appropriately treat things up front.
Right. So you'll be happy to
Same
know
with
that
us, Philip.
just a comment, Peter, this patient is now scheduled for a colonoscopy in the middle of December. So we'll see. Peter.
Well, I was just going to say that our gastros teach us that the fecal calprotectin, if it's a week to 10 days off an NSAID, is a very sensitive, cheap test for gut inflammation. And they've actually told us that under 50 rules out active inflammatory bowel disease, and over 150 needs a colonoscopy because although it might be IBD, it could also be bleeding polyps and malignancy, et cetera, et cetera. So they've given us those two numbers, 150, do something. If it's higher, 50, be reassured that it's not active inflammation, often NSAID. And we don't screen everybody. We only do people with symptoms. And it can be very helpful, like you were saying.
Good. So I'm glad to hear that there is some similarity in our in this. We're sort of new to testing fecal calprotectin. I can't I haven't done this a lot, but in our setting, I'm coupled with a gastroenterologist who really is he's been participating with us in teaching visiting physicians who go through a preceptorship where we teach them about PSA and AXPA. And he's been coming in and teaching us about IBD. So it's really been neat to reach across the aisle and learn from the gastroenterologist, just in the same way that we've been doing that with the dermatologist for many years. I'm curious, do either of you all have any comments about uveitis? There was a single row in the large safety database with Bimekizumab where it appeared that the frequency of uveitis episodes in patients with a history of uveitis was less in the Bimekizumab arm than in the placebo arm. But I know with the IL-17A inhibitors, historically, we don't think it harms and causes uveitis, but we're not sure if it helps. Peter, do you have any comment about the uveitis?
I've always thought uveitis and the 17s are neutral. They don't help, they don't hurt, they don't prevent it. And if you've got uveitis, that's a TNF indication. But I can't help feeling that it's like you're only putting people into trials of 17s now when it's the third, fourth who have no uveitis issue. And even then, it's only 3 per 100 per year get uveitis. So we're really talking about small numbers. And if you follow people for 24 weeks, even a few hundred people, etc., you're not going to see a lot of uveitis. So I can't help thinking it's a little bit of selection bias going into the trial, low risk of uveitis because of 17's history. But they did have lesser than you'd expect. The other 17s have done formal trials in uveitis and have been unsuccessful. I think BIM is doing a formal trial to try and answer that question as well.
Right. Terrific. Do any of you all have parting comments before we wrap up our session today?
You can go first, Brian.
Yeah, no, I'm excited about, I mean, it's for me, like I am excited to be entering and starting my rheumatology career in this kind of like pharmaceutical boom. I feel like we've now been in and is continuing at a very rapid pace. So it's a very exciting time to be having discussions like this where we have, I guess you call the privilege of the conversation is like, which agent do we use and not like, do we have an agent to use? So in a way, I kind of view it as maybe a good problem to have, if you will. And I think it's exciting that we like each ACR, each convergence, we keep hearing about these new agents that, you know, can potentially help our patients even more.
So I tend to think that this class has a safety advantage and they should be used early in the treatment algorithm. But Philip, you and I and Brian, we have those difficult to treat PSAs separate to the complex to manage that Grappa's trying to sort out. And it's in the difficult to treat, the non-responder, who I wish we'd be a little bit more scientific, no matter which 17 inhibitor we use, where we might actually measure a trough level and see if, you know, there's some issue with compliance or FC fragment being chewed up by antibodies, or in fact, they've got a trough dead smack in the middle of where it should be and they're not responding, we should switch class, because we're so lazy, we just, and so much choice, we just flick to another drug and do that for 6 months and then flick to another drug for 6 months. And it's a shame we're not a little bit more scientific about the way we use our biologics. The responder, no problem. It's that non-responder group that, you know, you and I all get sort of tertiary referrals now of someone who's failed 5 biologics. And you ask yourself, did they actually fail each of those, or we just take it on the word of the patient and the treating doc that that's what happened and try and find some other class of drug? I think it's a shame that we weren't like the gastros who were stuck with 2 biologics for so long that they started using levels to make sure they got every ounce of juice out of each one.
Yeah. Good points, both of you. So I'm excited about the fact that even though there are a lot, it's good to have more, because I think we do run into the problem of people running out of gas with one agent and do finding some ability to have benefit from another one. So the Canadian study that you presented, Peter, I thought was very useful to teach us a little bit about that. Small numbers, but nonetheless some optimism that switching within the class can be helpful. I think it's going to be good to have this extra oomph, so to speak, from inhibiting both A and F, and maybe getting a little bit better efficacy in certain domains, as well as having a little bit more durability. So I want to thank the listeners that are attending this Room Now podcast to learn more about what was presented at the ACR 2024 Convergence and our little team's efforts to teach you more about the interleukin-17 class, especially in PSA and AxSpA. So thank you very much for attending.
Thanks, Philip.
Thank you.